to another amazing day. Happy Tuesday. We have an amazing webinar here at the Phia Group called Benefits on the Ballot. I'm very excited to present this one today, a political update for the health benefit professionals. So folks, here's the one thing. I think you guys can pretty much figure out who asked to have this topic be on the webinar today. It definitely wasn't me, and here's why. I just can't talk politics. I mean, at least not with my family. But it looks like we're going to be able to talk politics with all of you. Literally this weekend, having a nice time with my wife, her sister, and her husband, and somehow somebody mentioned the word Trump, and I made a comment, and literally all hell just broke loose. I just wanted to run back to the car and just get away. So I try to steer clear of politics, especially since my wife is literally left of Cuba. I don't talk politics. It's not brought up in my house. But we got an hour packed of not just about talking about, again, what's going on when it comes to the election and so forth, but how it's going to affect you, your business, your clients, and in general, just health insurance and its costs and accessibility, et cetera, for years to come. I am in the wonderful Canton office, our new headquarters. It is great to be here. I'm in a really good mood today, and there's a big reason why. It's because the Cleveland Indians' magic number to make the playoffs is 1. 1 win or 1 loss by any other team behind them, and they make it to the playoffs. So I'm very happy about that. So Matt, let's get to the next slide. So what are we going to talk about today? PGC FAQs. I think you know who's going to be talking about that. Political update, the candidates' healthcare plans and their impact on you, just like I promised. Changes coming to drug pricing and how to prepare for that, as well as lastly, changes coming to price transparency. We all know what that means and how to prepare. Next slide, please. So there is our amazing panel. You see that good-looking guy on the left? That's me, Adam B. Russo, the co-founder and CEO of the Phia Group. With me, as always, is the best executive VP and general counsel in the country, Ron E. Peck. Say hello, Ron.
Hello, Ron.
Ron made it. Ron, how are your Mets looking? How are the Mets looking this year?
So I don't know about magic numbers, Adam, but I do know it'll take some magic to get them into the playoffs. You know, it's funny. Someone told me there's a 50-50 shot this year, which means half of the teams are not making it. So, yeah.
So, Ron, listen, just so you know, a lot of weird things have happened this year. Anything can happen, buddy. In addition, Jennifer M. McCormick, our Senior VP of Consulting. Say hello, Jen.
Hello.
The real reason why people line up. You see the numbers that skyrocket the minute Jen just talked? Amazing. And last but not least, Mr. Brady C. Pizarro, our Director of Legal Compliance and Regulatory Affairs. We call it La Cara. Say hello, Brady.
Hello, Brady.
So, folks, just so you know, I will be making fun of Brady this entire time. He wrote me an email earlier today that I have to bring up. I'm not going to bring it up right now, but Brady's going to be freaking out until I do. So, anyways, next slide, Matt. Folks, as always, try to stay ahead of COVID. Put on that mask, and while you're doing so, contact us at pgcreferral@phiagroup.com with any and all of your COVID-19 questions. In addition, while you're wearing that same mask, make sure you also follow us on LinkedIn, Matt. Look at that. He's behind the times already. We have almost 5,000 followers on LinkedIn. Go to LinkedIn, search for the Phia Group. In addition, make sure you download our podcasts. We have some great ones out there on Apple Podcasts or on Google Podcasts. Or feel free to go to the Phia Group website under media, and you'll find all of that fun stuff. Next, I want to make sure we give a shout out today. Who's the shout out to? Neil Quinn, the Vice President of Strategic Initiatives at Risk International Benefit Advisors. Neil told us that he's highly allergic to status quo and carries an EpiPen filled with contrarian serum to counteract severe exposures. Unfortunately, with my line of business, it gets a lot of use. Don't know what he's talking about? Weird quote. If that's the best he can give us, that's okay, Neil, because we're happy you're listening. We appreciate it. You will get the goodie bag. I am not, because I made mistakes in the past. I am not going to tell you, Neil, what's in the goodie bag. Why? I've had more people contact me, not about how to make healthcare better, not how to lower overall costs, not how to offer more benefits to employees. More people have emailed me asking why they didn't get a t-shirt, okay? So folks, I'm not gonna tell you what he's getting. It's just gonna be a lot of cool stuff, Neil. So be on the lookout for that. We appreciate you listening. And to also the thousands of you, and I mean that, thousands who dial in every month. I'm not sure why, it ain't to listen to me, but I appreciate you doing that. Next slide, Matt. Pay certification. If there's ever a time to get pay certified, it's now. It's free. Why wouldn't you want your staff to be educated and understand self-funding and what's the good things and bad things about self-funding, federal preemption, adverse benefit determinations, everything. Feel free to jump on, talk to Michael Vaz at mvaz@FAQs.com to get more information and get yourself knowledgeable about the industry. Next, we are very proud again to share with all of you that those subrogation clients of ours will again be receiving these subrogation value reports. But in addition to that, Matt, let's go to the next slide. For our balanced billing reference-based pricing clients, we are also going to be sharing these new reports as well as unwrapped value reports for those of you who work with us on Unwrapped, where we literally promise you that you will not be getting ripped off any longer on out-of-network wrap network fees or ridiculous discounts. Instead, utilize Unwrapped for that. Next slide. All the outreach in regards to all of our value reports come from our client success team, headed by Tim Callender, Rebecca, Mike, and Krishna. That's who they are. They make sure that our clients are happy. They make sure that you are successful. And if you're happy, you're successful, then guess what? I'm happy too. Next slide. Phia International. I'm flying through these today. I feel it. I told you, the Indies magic number being 1, it makes me feel good. As you all know, we have now a Phia International division. The website's coming. All the information is there. That good-looking guy on the left, Jason Davis, and that not-so-good-looking guy on the right, Nick Fitzsimmons. Just kidding. They're the 2 guys that head up our Phia International claim negotiation business. Please, feel free to reach out to them with any of your needs or just to give them a nice congratulatory, that's, good job. Next slide, please. So, folks, you see those 2 guys there? We were both on this call, myself and the amazing Ron Peck. Ron will be speaking on October 14th at 1 o'clock, talking about COVID-19, who, what, and when. I will be talking the next day on a self-insurance claims classroom where anything goes. So if you go register on SIA, you'll be able to see all that information there. I hope you do so. But before I go any further, I want to make sure I bring up Brady. So earlier today, and folks, this is why I have to do it. I apologize, right? But earlier today, I made sure that I brought up the fact that I received an email from Brady, and he specifically said that he wanted to make sure that I gave kudos to Amanda Lima and himself and him. He wanted to make sure I gave kudos to him. He wanted me to make sure that I mentioned the amazing work that he and Amanda have done when it comes to the future leaders sessions. There's going to be 2 of them at SIA in October. So yes, do I think it's good that he reminded me? Of course. But I think that maybe he shouldn't have brought up himself. He could have said, hey, Adam, would you mind giving kudos to Amanda Lima about what a great job she has done when it comes to the sessions for the future leaders sessions at SIA. But he had to throw himself in there. So I'm going to call him out and say, Brady, you should have known better. If you're going to call yourself out and ask me to give you kudos, you should have probably known I was going to make fun of you. But anyways, honestly, folks, please register for SIA, listen to our sessions, and make sure you listen to Brady and Amanda's sessions as well, because they did a great job putting that together for the future leaders at SIA. So with that, and I'm done, I'm going to turn this over to Jennifer McCormick. Take it away, Jen, with last month's PGC FAQs.
All right. I don't know if I can top that conversation about Brady, but what I can promise is that I can tell you what's going on with some of the questions we're seeing, and we couldn't start the conversation without bringing up COVID. So the first question that has been on a lot of people's minds is talking particularly about the pricing when it comes to the regulations and the COVID-19 test. So specifically, a plan had reached out to us regarding what obligation they had when it came to paying the provider's posted cash price and whether that was applicable specifically to that COVID-19 test itself, or whether or not that actually applies to any and all services that were provided in connection with the administration of that test as well. So this is a sneaky little question here, and you have to dig into the regulations to actually understand what it is that is being called for. So the obligation actually, as it's noted here, only applies for the charges that are set up for the actual test. However, the provider is required to post whatever that cash price is on their public internet website for any and all of the services that are listed. However, you're only required to post the cash price for the test itself. So even if they did decide to post the cash price for any other expenses that may be related to the administration of that test, the supply, what have you, the payer does have to pay for that price. But according to the actual regulations, which are listed here in case you want to go double check or save this to your notes for later on, you're only going to be in violation as a provider if you fail to actually post whatever the cash price would be for the actual test itself. So keep that in mind. Just because they are posting all of the prices doesn't necessarily they mean to, or that they're required to according to the regulations. They can, but don't have to. You're only going to have to look for potential concerns or violations on the provider's behalf if you're not actually seeing what that cash price is as it relates to the specific test. All right, next slide, Matt. All right, so this is a question. We're going to switch from what a plan has been asking to what a TPA has been asking. So this is something that has also been coming up pretty recently in the sense that there is more remote status, more concerns potentially with how we're using PHI, the obligations and requirements when it comes to HIPAA, and what it is that we need to do as we're getting other vendors or other entities involved in the process when we're sharing information. So specifically, the question is here, as a TPA, a client is asking to transmit data to another vendor that that individual plan is working with. Does the TPA then need to have a business associate agreement or a BAA with that particular vendor as well? Well, it wouldn't be an answer to a question if we couldn't say it depends. And obviously, this is going to be variable based on the particular facts and circumstances that underline what the particular relationship is. But the first question is, whenever you're getting questions like this or similar to this, is ask yourself, what is the relationship that exists between the two parties? And remind yourself, again, the definition of these terms as they are found within the HIPAA regulations. So a business associate or a BA is the entity that performs the service for a covered entity. And that's the one that is involving that use of the PHI or the protected health information. Now, it's a subcontractor that is going to be the party that's actually doing whatever the service is for that particular covered entity, and then thus using the PHI and being subcontracted through that business associate relationship. So it's possible here that one party is the business associate of the covered entity, and there's another party, also a business associate of that same covered entity. That doesn't necessarily mean that they are going to be business associates of each other. So many times there are going to be multiple BAs or business associates that are working together, but they don't otherwise necessarily have a real connection or relationship or duties that they're owed to each other. They're just independently operating and doing obligations that they are required to follow under the HIPAA guidelines and rules. So the short answer to this question here is make sure that you look at the underlying facts and circumstances and the actual connection between the two entities before you thoroughly answer that question and figure out whether or not you're actually going to need or be required to sign another HIPAA agreement. All right, Brady, I'll turn it over to you.
Thanks, Jen. You know, it's hard to overstate.
Do we want Brady to talk? Do we really want Brady to talk today, guys? I mean, after that email you sent to me. All right, Brady, I'm getting a lot of texts from people saying, you know what, I think it's time to get Brady off these webinars. Just throwing it out there. Ron, what do you think?
You know what? I mean, I would think the political webinar is his swan song.
I mean, yeah, that's how we'll do it. We'll end, Brady, this is what we'll do. We're gonna, since this is all you, and this entire webinar is basically, your thing, we're gonna let you all with the bang. How's that? This is it, folks. So Brady,
I like that.
do your best job. You like that, huh? Anyways, just
well,
kidding, Brady.
Thankfully for me, Adam, the political chaos keeps happening in this country as it relates to healthcare and our industry. So there's plenty of work for me to do. And in this case, if you thought this election season and this year couldn't get more chaotic, you were wrong, because we have to acknowledge the death of Justice Ruther Ginsburg, which is a tremendous loss both for the court, but really for the whole country. Just over 5 feet tall, she was a giant in our profession and someone who shaped the law with respect to healthcare issues, to gender equality issues. And her absence now on the court creates a significant void. on a lot of important cases that are important for our purposes, because as the court's liberal leader being gone, she's now shifted the court to the right significantly. And it's set up a situation where there's now 8 justices, and it appears, if you're following the news every 5 minutes like I am, that the president is going to nominate someone this Saturday, likely a woman, obviously a conservative one, and the Republican-led Senate has all but said that they have the votes. I think just recently Senator Romney came out and said he would support a nomination being jammed through. And so this is happening. I mean, we covered this last time with a justice and the hearings that go on. Typically it takes something like 46 days, I think, on average, maybe even a bit longer to have a new justice appointed and confirmed and throughout that process. But here, with an election so close, where the votes have already been cast in certain states for early voting, this is a big deal, and it's going to throw us into a lot of chaos.
Brady, what's your forecast? What do you think is going to happen? Just keep it simple. Tell us what you think is going to happen.
I take unfortunately the pessimistic view, being someone who knows a lot about politics. I think the president is going to get his pick through. I think this person could be confirmed before the election. And that's going to be a big deal, because this election could be contested. There could be, who knows how this will result. And so you don't want to have a 4-4 split on a case deciding the election. And you also would have a problem, I would guess, if you have a Trump nominee deciding how the election goes too. So, but I think it's going to happen. I think this person's going to get slammed through, and we're going to see a lot of chaos result from it. But there's a lot of fallout to talk about with respect to certain healthcare cases that most of you listening in are very concerned about, or you should be very concerned about. Of course, we're talking primarily about the Affordable Care Act. And really, we've covered the previous lawsuits against the ACA. I think there's been 3 major ones before. Some of them predate even me. But I think at this point, it's fair to say that the Affordable Care Act is in more danger now than it ever has been, because without Ginsburg on the court, and it's fair to assume that whoever replaces her will be conservative, the law could get struck down. And so there are a couple of different possibilities here about how this could go. There's some different scenarios. You could have the oral argument, which is scheduled for November 10th.
Brady,
that could be delayed.
Brady, we should go to the next slide then, I'm assuming. And then, so let's make the assumption that you say happens, right? So that now Trump has a replacement and she's a conservative. Let's make that assumption as we talk about this next slide.
Sure. So on the next slide, then you can talk about how the background here, and this is important to remember because it's going to inform how this could play out, right? We have a case where essentially the lower district court ruled the mandate unconstitutional. It was appealed to the Fifth Circuit. The Fifth Circuit said, we agree, it's unconstitutional, the mandate, but they kicked the case back down to figure out how much of the case had to be, or how much of the law rather had to be struck down. That's when the Supreme Court took the case, right? So if you have a situation where there is a tie before an appointee, which is possible, because again, if this person's not appointed to the court before oral argument, which is to say November 10th, then it's almost certain that justice would not weigh in on the case, because that's not typical how this happens here. So with a 4-4 split, the case goes back down to the lower court, which means back down to the district court, and it looks pretty bad for the ACA. If you assume that the pick does get through, and you have a 5-4 majority on the court, then I think what was likely to happen is you would have a case where the 5th vote could decide to strike down the ACA. But we're getting a little ahead of ourselves, because I think the likeliest scenario, in my view, is that the case is heard next year, and that would be because either the argument is delayed in a 4-4 split, or the case is sent back down, in which case the litigation effectively starts over. So I would be shocked if we see the law struck down this year. I don't think that's going to happen. But I do think if the process starts over, if the case is either delayed or if it's sent back down to the lower courts, then I think it's a fair game that this law could be struck down. I also think a wild card is whether the president actually releases his replacement ACA plan, which he hasn't really technically done. We'll talk about that in a few slides. But again, we're waiting to see really this week who the president picks, if she gets confirmed, and what the timetable is for that, if it happens before November 10th. So we'll have an update definitely in the next month's webinar, because we'll know a lot more about what has happened in that case. So on the next slide, we can talk about some of the other issues in the state of the race, right? One thing I just want to add as an epilogue here is what happens to the court matters not just for the ACA, but there are some reproductive rights cases we're watching too. Remember last webinar we covered a Supreme Court ruling on the contraceptive mandate case in which employers are now allowed to exclude coverage for birth control if they have a religious or moral objection. So there are other cases, including Roe versus Wade, which potentially could be up. But in terms of the polling and how this has affected the race itself, it turns out that it seems that Democrats and Republicans are equally energized by this death on the court and this vacancy. So that hasn't been affected much. But if you look at the national polls, you still see that Biden has a lead, a significant one in most national polls. But look at that graph on the bottom left I put here. There's a note here, electoral votes if state polls are as wrong as they were in 2016. That's how you see a Trump victory. So we'll see how that plays out.
So Brady, if the exact same thing happens as what happened in 2016, Trump wins.
Yeah, pretty much. I think it all comes down to 3 states, actually, and some of them are listed on the right here you can look at, but there are 3 states that Trump won last time that Democrats were shocked by, or Hillary Clinton was shocked by. Those are Pennsylvania, Wisconsin, and Michigan. If he wins those 3, I think game over. And then again, the ACA, the fate of the ACA itself, I think, is significantly, imperiled. All right.
But in Michigan,
to talk more about some of the
Brady, in Michigan, even if 2016 were as wrong as 2016, Biden would still win by 2. That's what you're saying.
In Michigan, yeah, because that's what the polling shows. But again, the polls could be even more wrong than they were in 2016. We'll have to see. I think a lot could shift. Really, the first debate's coming up next week, and then a couple more. That may change things. We'll have to wait and see. But I do think that it definitely will impact. Whoever wins this election will impact what healthcare looks like, not just because of the pandemic, but because of the ACA being left in the balance. But the polling on the ACA is popular, and it's why a lot of the candidates' health plans, or now the 2 remaining candidate health plans, look a lot like the ACA. And so you can see when we move to talk about Vice President Biden's plan, Ron has all the details on that, and you'll see that a lot of the ACA remains intact, or at least that's the intention with his plan. And so for that, I'll turn it over to Ron.
Thanks, Brady. Thanks, guys. Good stuff so far. So, before I get started, one thing that I've definitely noticed in general when we work with the industry is because we're dealing with outliers and high costs, we often have benefit plan administrators and clients that are saying, can I move this individual, this high cost individual, off the plan? Can I shift the responsibility onto another payer? And if that's your philosophy and you see, hey, lowering Medicare to age 60, your knee-jerk reaction may be, hey, great, I can shift a bunch of high cost participants onto Medicare and remove that cost from the plan. But if you look at self-funding and health plans and really insurance in general, you recognize that while there's some outliers, you pretty much want the healthier people to remain on the plan because it's their contributions that fund the overall risk. And so when you look at lowering the age for Medicare to 60, you have to think, I might lose a few high-cost individuals, but I'm also potentially losing some people who would be contributing to the plan. So it's not necessarily a great thing once you dig in. The other thing that is very relevant here as well is this concept of Medicare for all who want it, or a public option. And I worry, again, about things like adverse selection, where the sickest of the sick, the people who are high-cost individuals, they're willing to pay a little more for the bells and whistles. So the quicker admittance to a provider, the better treatment, the lower out-of-pocket share on a case-by-case basis, more selection or more choices when it comes to provider, things that we tend to throw at Medicare for all as negatives and benefits of our private plans. An individual who has a pre-existing condition or a costly condition, they love those things. But the healthiest of the healthy, right, who they don't think they're going to use healthcare anyway, they're just looking for the best price, right? They're looking for a bargain. So one concern I do have about a public option is, are the low-cost individuals whose contributions are really funding the overall plan performance, if they all go to this public option and we're only left with the people who have specialized needs, that adverse selection could be bad as well. And one last thing to think about when we look at both the idea of having Medicare drop to age 60 and also creating a public plan, along with the adverse selection, is the issue of payment, right? Medicare, public option, they keep their costs down by paying hospitals and providers less. And we know already from our experience with Medicare and Medicaid today that those physicians, those hospitals, those providers, they shift the cost onto the private plan. So if you have more and more of the population on a Medicare plan or a public option that is, based on what providers have told us, ripping them off, they're going to shift that shortfall to the private plan. So it's not just a matter of competing with these public options in Medicare for all, but you're actually going to be handicapped as these providers are losing money on these other patients. So not necessarily great things. When you talk about boosting the Affordable Care Act, that's very interesting because hitching your wagon to a horse that's currently in front of the Supreme Court and may potentially go down as unconstitutional, very interesting to see that. You would think that if, I guess you have to have a backup plan, right? That if the ACA is unconstitutional, do you have a proposal that closes that loophole? And one last thing that's very interesting, and I read an article, guys, about the removal of the mandate, which has really been sort of the linchpin that's allowed this case to proceed. That removal of the mandate, what I read, had very little impact on the number of people enrolled in the ACA. So it's funny to see that something that really had very little impact is actually now causing all these complications. And another thing I want to quickly touch on is stopping surprise billing. Listen, surprise balance billing, that's an issue both sides of the aisle want to address, right? That's a bipartisan issue. We tend to get very excited about that, but please remember, surprise balance billing is not the same as all balance billing. Surprise balance billing really is just sort of a subset when we're talking about emergency services or an out-of-network specialist at an in-network facility where literally the balance bill is a surprise. It's not necessarily meaning that, hey, I can get rid of my network, pay everything at a % of Medicare, and balance billing is illegal in general. Is it a step in the right direction? Absolutely, but it's not a cure-all. And then as far as the prescription drug reform, we're going to dig into discussions about the drug reform in general, both from the current administration and proposed. But again, you see that the drug companies and the PBMs are definitely a target. And you're talking about also how things are negotiated, how things are priced, and drug importation as well, which has been a hot topic for us frequently. So we can go ahead and move on to the next slide, and I'll pass it back to you, Brady.
Thanks, Ron. I'm glad you mentioned some of these issues that also appear on President Trump's healthcare proposals, because there should be some ray of hope for us, right? That a lot of these things appear on both sides of the aisle. We should see some movement. We haven't seen much movement, frankly, from Congress. And that, by the way, is the excuse we've been given from the Trump administration for why we haven't actually seen his healthcare plan. In the news a lot lately, you keep seeing, references to this secret plan. He keeps promising a plan. There is no actual plan, nothing in writing. There's a bunch of proposals. And in fact, his chief of staff recently said on the news that his plan is basically a combination of executive action with a legislative component, but they don't have that legislative component because Congress hasn't really done anything because they just keep fighting. But look at the list here. We see a lot of the things, I guess, again, aside from the Affordable Care Act, which Trump has said he wants to repeal. The truth is, as I mentioned before from the polling, a lot of pieces of the ACA he wants to keep. So protecting those with pre-existing conditions. You can bet that his plan will have some kind of federal law that requires that. Prescription drug reform. We'll talk more about some of his ideas in detail in a few slides, but ending surprise billing. Again, like Ron said, it's going to depend on what or who gets to decide what a surprise is. Who should be surprised. That's going to be the big deal about how much of balance billing is ended here. But I think air ambulance is a good target there. It's been mentioned in a lot of even conservative articles on this topic, so we could do some action there. But we haven't seen a complete plan. We expect to see one. My instinct says it won't come out until after the election because, frankly, it's not helping or hurting his polling by not having one out. But recognize here there's a risk, right? There's a risk in having a plan that consists of a series of executive orders, which is how this president has governed in the realm of healthcare for the past 4 years, because almost every single one of those has been challenged in the courts. And very many of them have been struck down, including his one to have list prices for drugs and TV ads. Association health plans are struck down. A lot of the reasoning because the agencies charged with implementing his executive orders are exceeding their authority under the law, and the courts are checking them. Now, if we have a Supreme Court that's stacked, 6-3 or, in favor of the conservatives, maybe that goes away. But that's still a lot of time and a big process for getting this plan done. So I still expect that once this election's resolved, Congress will take a more active role in working with the president. That is, of course, unless the Congress switches to Democrat control, in which case we'll be starting over once again. But that's as much of the plan as we have so far. And the rest of this webinar will be about going into some of the more details about some high interest areas that the administration has been focusing on. So next slide, please. turn it over to Jen.
All right, thanks, Brady. So it sounds to me like everything is crystal clear. We know exactly what to expect and when to expect it next. No, just kidding. So it sounds like instead we're going to need some sort of seatbelt and snap so we can figure out what we need to do. Well, what we need to do is to consider this as an opportunity. Maybe this is something that we should embrace. Of course, I'm sure we're all feeling lots of fear and anxiety, not only for what's going to happen next in the world, but for our companies, for our employees. So let's instead view this as an opportunity, or we can look to other places, things that we can actually do to create some change and maybe enhance some of the experiences or enhance some of the benefits that maybe people are offering. So we do know what we must do. So in order to survive, one of the things that we must do is follow the regulations, the rules that are actually in place when it comes to any sort of leaves that maybe not only are at the federal level, but maybe at the state level or even the city level. Every day there's a new regulation or something that is coming into place. Different schools and different cities are coming up with whether or not kids are going to a hybrid learning or they're actually going back in person or whether they're all going to be remote. The same thing is true for daycare, whether it's open, whether it's closed, or offices, whether they're open or whether they're closed or people are working remotely. So it's important now to use this as an opportunity to make sure that you're informed about what it is that is important for you, for the company, for the employees, and find areas that you can actually use to take advantage of. So a quick example here about maybe something that as an employer would get you to be thinking about how you could be a little bit more creative with your benefits. In my neighborhood, for example, it seems like in the past 4 weeks alone, the past month, everyone has gotten a puppy. You walk outside, there's puppies everywhere. And now maybe that everyone has a new puppy, they're working from home, they have the opportunity to train a puppy, get them all up to speed, offer the companionship that they're looking for from being isolated for the past 6 months. Maybe pet insurance is a new benefit that they might find valuable. Maybe that's not something that they previously needed, but maybe now it's something that is actually important to them. Maybe you can actually start thinking outside of the box to say, hey, what are the types of things that I can do? Maybe I have some employees now that are needing to move to a new remote setting. Maybe they need to move out of state to take care of their parents or to be closer to somebody else who can maybe help with childcare during this uncertain time. Maybe you need to look at your actual handbook policies and say, shoot, maybe I need to revise this now that I have other employees that are in different locations, or maybe I need to look at some of the actual teleworking policies I have in place and make modifications to change those so they actually align with creating these opportunities to enhance the work environment for our employees. And what about plan language? We can't not talk about plan language or plan benefits. There are a lot of potential new benefits that people are asking for. Maybe there are certain things that could be enhanced, maybe offering more frequency or visit limitations on particular things. And maybe by offering these increased benefits and being a little bit creative or maybe taking a risk and maybe offering something maybe you wouldn't otherwise have, maybe that's otherwise going to reduce the spend in another area for an employer. The point is just, so this is a time that we all need to be resilient and make sure that we can make all these modifications, be as creative as we can when it comes to what types of protocols or committees or engagement it is that we can actually create for our employees, and then looking at everything as a whole to figure out how this is actually going to enhance the experience for everyone. So what's a quick list? Matt, if you want to switch to the next slide here. Keep up, pay attention. There's going to be a lot of litigation, a lot of regulations that we're going to expect to see, especially in the coming months, coming weeks, when it comes to a lot of things we're going to talk about in the next few slides. So there are certain things that haven't yet necessarily been acted on. We talked about a couple of these things here too, about the provider relief fund here. This is something that we are looking for, that additional funding for these providers. We could make sure we're continuing and extending the time frame which the telehealth benefits would be available under the plan. Maybe the possibility of how this COBRA subsidies is actually going to play out. A lot of things haven't actually panned out, but that doesn't mean that they won't in the future. So we need to make sure that we're paying attention to that, and that if there is a modification, we're actually going to be able to adapt and be flexible to do that. But two of the most important things before we dig a little bit closer into a new topic to pay attention to are mental health and telehealth. So in the past, I know we've discussed these as a more prevalent topic on the actual webinars, but for mental health now, especially when things are changing, we don't know exactly what to expect in so many different aspects of 2020. There are a lot of negatively impacted individuals who are having some maybe new barriers to care that they otherwise would have been able to get, but maybe they can't get that care due to social distancing or opportunities for an appointment, or maybe something's not necessarily available. So make sure that we're looking into this and considering whether or not we need to expand the benefit for mental health services under the plan. The other thing that we've talked about in the past that's important that we don't overlook is for our telehealth services. So there is a distinction between a telehealth benefit being offered via a particular vendor and then being offered as a benefit in the plan as well. We want to make sure that if this is a benefit we can offer, we're not offering it in a very narrow, targeted way that would potentially preclude the individuals from getting other telehealth services that they may necessarily need and not have access to as a result of the plan language. So pay attention to this and make sure that we are addressing all of these things in as creative as a way as we possibly can, being mindful of our employee needs. All right, Matt, let's dig a little bit more into this rule about copay assistance. So I know this is something we have also talked about before, but when we're talking about what it is that we need to do and how we can make these modifications and the benefits that are important to us, this is one that we can't overlook. So this actually took effect about 2 months ago in July. And as a result of this rule, which I'll go over again, this is going to allow plans the opportunity to, at their option, decide and determine whether or not they want to count copay assistance, whether it's manufacturer assistance or a coupon, whatever the actual substance of it might be, towards the employee's cost-sharing amount, which works towards the maximum out of pocket that it has to pay. So obviously there are going to be some state rules or state regulations that might come into play that could impact that. But generally there was some back and forth about the extent to which this would have been permitted, whether this only would have been permitted in a circumstance where there was a generic equivalent or whether there wasn't. But now we know that this is something that is going to be permitted regardless of whether there's a generic that's available. So the thing to keep in mind here too is if you are, for example, a plan that is a non-ERISA plan or not necessarily subject to the federal rules in the state of Arizona, Illinois, Virginia, or West Virginia, there might be a regulation that would prohibit the extent to which you can actually apply this rule. So pay attention in those particular states. For example, in Arizona is limiting this to situations where there actually is a generic that would be available. So there's other states that are continuing to adopt and look into these potential rules. So this is something that we might need to actually look at our plan language and make sure that our practices are aligning with what we intend and what the states will allow. All right, Brady, I'll turn it back over to you.
Thanks, Jen. Now, a quick epilogue to one of the last slides you just covered, Jen, is this issue of mental health claims and things that plans should be identifying now as opportunities. I want to just add that list quickly. This issue of people who are foregoing care, right, because of the pandemic might save you money now in the short term, but if people are not getting the care they need to maintain chronic conditions or identify illnesses now, it could cost you more money in the long run. So just add to that list there of things you want to identify now and be careful of. In terms of things that have happened, the executive orders on drug pricing are a big deal. They were signed back in July, 4 of them in particular. We'll cover them in some detail here, but I want to just mention someone sent us just now a very smart comment on these drug reform regulations and noted that they need to be across all payers, not just government programs. That's a very perceptive and good point. The reason I think that you see this, by the way, is because it's much easier if you're issuing an executive order to apply it to the government if your goal is to not have it be struck down by the courts. I think that's what's going on here. I also think that a lot of these executive orders you'll see in a second are creating a model that can be applied to the private market. And so expect to see that as well. I'll skip number 1 because I have a slide on it next on prescription drug importation. I want to talk about 2, 3, and 4 a bit here. So Medicare Part D drug rebates. So this was an executive order that was signed here that essentially says that rebates that would otherwise go to PBMs in the Medicare program have to now go directly to the consumers. You're talking about approximately $29 billion in rebates, a lot of money here. But I think that the idea here is it's creating this template to be used, again, potentially in the commercial market, saying that The administration thinks drug rebates are driving costs up. Drug rebates are bad, and therefore they should be passed directly on to the consumers at the point of sale or to the plan. In the case of self-funding is a possibility there. So this is an example of, I think, a good area, a good template to follow that applies to the Medicare program that could be copy and pasted onto the private market. Number 3 here on the cost of insulin and injectables used in federally qualified health centers. This was largely in response to the drug hearings from last year that were focusing primarily on the cost of insulin. It was a huge outcry on the cost of insulin, and this effectively only applies to these federally qualified health centers and manufacturers who are selling them to these programs under the 340B program. So again, just applying here to the government programs. The same is true of the most favored nation proposal, which you've heard the president talk about a lot if you've been watching any of his coverage in rallies and on TV. Effectively here, what he's doing is requiring that drug manufacturers match the price, the best price that they give to a favored nation. So an international country who they're selling a certain drug to at a lower price, they've got to match that price when selling it to Medicare. What's important to note here is that an earlier version of this executive order just applied to Medicare Part B, which covers drugs administered in doctors' offices. This rule expands that to apply also to Part D, which includes drugs sold in pharmacies, and that's a lot more drugs. So what you're getting here is, again, just affecting the government program at this point, but it's really a price control. And importantly for our purposes, it's establishing an international reference price, right? And you've heard that term before in context of RBP. So are we establishing a benchmark for Medicare pricing for prescription drugs? We teased this before as a possibility, I think a couple webinars ago, maybe even a year ago, but now we've got the rule here. No one's seen the text still of this rule, by the way. We know what it contains, but some estimates say it could be about 126% of what other countries pay, down from about 180%, which is a significant reduction. So on the next slide, I'll talk about one of the other very important executive orders in some more detail, which is prescription drug importation. So if we can go to the next slide, we'll see here that what this executive order has done is really, again, in response to a lot of market pressure on drug pricing and in response to a number of states and municipalities that already do this, the administration has a plan that would allow states, wholesalers, and pharmacies to import prescription drugs from Canada and sell them in the U.S. So again, you have to be one of those entities to be covered by this rule in terms of importing the drugs. They have to come from Canada, which we've talked about in other contexts and settings about why Canada is an ideal place to choose, being a tier 1 country and having similar rules in place. But there are still a whole host of problems to navigate here. But the point is, this is an opportunity. This is something you can identify today. The administration plans to allow this. It also signals that if you're currently doing this, right, in line with the non-enforcement policy, you can bet that the non-enforcement policy is likely to continue since the administration now has a plan making this legal for these entities, right? So that's a really important development here. And again, it's a special focus on insulin and other biological drugs that are particularly expensive and have been in the news recently. So those cover the 4 big executive orders that were covered on drug pricing, but we want to talk about in a more deeper dive the rule on price transparency. And for that, I'll turn it over to Ron.
Thanks, Brady. So real quick, when we look at all the different things that they're looking for when it comes to transparency, the provider, the payer, price, quality, the one thing that's, I think, the easiest target and therefore has been the first to see movement has to do with price. And when we talk about price, we're talking about the price being charged by the provider. We're talking about the negotiated rates by the payer. And one of the reasons, or sort of the argument that the regulators that are in support of this rule have used to support the rule is that they want the patient consumer to be more educated about their cost, right, the cost to them. But I think that's kind of funny because when you think about it, right, knee-jerk reaction when I hear that is to laugh because that consumer, meaning the patient, is not the one who's necessarily paying for the service. Now, you and I know, right, that you pay for it eventually, right? If my plan, if my insurance is paying more for healthcare, not only for me, but for my fellow members, eventually my rates are going to go up, my premium, my contributions. But there are so many degrees of separation between me and that event. The date I get treatment and the date my premium goes up, I don't necessarily connect the two. And it's that sort of separation between the entity consuming the care and the entity paying for the care that kind of scraps that argument that this is basic economics. right? And another thing about the price that I have to pay, if I'm a payer and I want to reduce the amount that you think you're paying, I could take a $100 copay, I could zero it out. Now you have zero copay. Hooray for me. The fact that I raised your contributions by 200% and I'm now making more off of you as a plan member, well, that's beside the point. So, it's not only a matter of addressing the cost of things, but also educating people about how the cost of things actually impacts you as a plan member in general. So I think this is really more about education than anything else. And, I'm glad that the arguments are being made in support of transparency. I am a big supporter of it myself, but I wish that there was more attention being paid to the true reason for it, which is that element of education, ensuring people understand just how random all this payment is. Because other than that, there are a lot of places where it's not the same as Kelley Blue Book knowing the price of a car, right? Because the consumer and the payer are separate. So let's move on to the next slide, and we can get into a little detail here. Brady, I got to ask you, I want you to go ahead and ask me, Brady, how much it cost when my father took me to go see Transformers, the animated movie, in 1986. The answer is I don't know, and I don't care. I don't care, Brady. I don't care. You know why? Because I wasn't the one paying for it. So, that just kind of, I think when we talk about the underlying assumption that people care about the price of things, if you're not the one paying out of pocket, even though I could go back in time and I could tell Ron going to the movie, oh, I'm so excited and I don't care what it costs because my father's buying the ticket, I could say, well, Ron, that's $3, that's $5 that your father's not going to be able to spend on a Happy Meal, right? So, yes, it doesn't matter who's ultimately paying at that moment. It trickles down to the end user. But people don't necessarily understand that or appreciate it. So when the HHS is quoted as saying they want better informed consumers, somehow knowing the prices is going to create better informed consumers, I don't necessarily think that's true. There's a disconnect between the provider's charges and the discounted rates and the actual out-of-pocket cost to the patient. So for this to have an impact, ultimately, and we can move on to the next slide on this one, I think that if you're going to have an impact, really what you end up needing is an educated populace. But before we talk about how to actually move the needle as plan administrators and do something to accomplish that, I want Jen to jump in a little bit here about what the rule requires from the provider perspective.
Sure, thanks, Ron. Okay, so, quickly there's really two things we can summarize or break it down to for what it is that this rule is doing. So first, and importantly, is that on an annual basis, now hospitals are going to be required to provide a machine-readable file that has the negotiated charges or the rates for all these various items and services. Items and services generally meaning anything that is a supply, a procedure, room and board, using facility, anything else where there is some sort of standard charge for the actual service. The second thing is that for the 300 shoppable items and services, to including whatever those 70 are that are defined by CMS, that they have to provide that information, display this information, being the gross charge or the negotiated charges, in a consumer-friendly display. So specifically, there are a lot of rules that are kind of breaking down what that entails on a line-by-line description, a charge, whether there's a negotiated rate, and how we're identifying this, and a lot of different ways that this is going to have to be searchable digitally, electronically. And when it comes to the actual consumer-friendly display highlights, there's also a laundry list of a lot of things, codes, how this information is de-identified when it comes to those particular charges, a lot of nuances for how this must actually be provided and what hospitals must comply with when it comes to this. So this transparency rule and regulations, I want to note here that this isn't something that is new. The concept of this has been around for many, many years. In fact, this is actually something we started talking about at the introduction of ACA, believe it or not, 10 years ago. And there have been lots of rules and regulations that have just made this confusing. So the goal here was to invite the opportunity with this transparency and with these specific definitions and details to try and make this as not confusing as possible by also attempting to provide some sort of out-of-pocket estimate for the patient. But whether or not there is going to be tools or the ability for consumers to access this information in a way that is both going to be understandable and consumer friendly is yet to be seen. So let's jump to the actual impact that this is going to have. Ron kind of alluded to this a little bit already. The impact here, there we go. The impact here is going to hopefully offer these additional sources for where individuals are going to be empowered or encouraged to actually have more control or say in what it is that they're doing when they're actually receiving this care. We hope to empower them to maybe shop around to make sure that they're getting the best value. And the hope is that by giving them this particular information, they can make an informed healthcare choice and an informed healthcare decision. So by doing this, that they are aware of what it is that there is a market for other physicians or other hospitals that are competing to get access to these patients and reduce the cost. And the example here that we have utilized is talking about the Surgery Center of Oklahoma. So if you are interested in seeing what a particular price might be, you can look to the website. It's like a menu at a restaurant that outlines the particular fees or the prices that are associated with the actual services that are being provided or being offered. So this is a situation where people know that they can understand at the outset prior to actually receiving their care, so they can make that informed decision about what it is that it's going to cost them specifically. There's an example here about somebody who was in California. They needed a particular surgery, and while they had maybe would have spent $30,000 if they received that care in California, by traveling to Oklahoma, they only paid $5,000. And I understand that maybe there is a little bit of a nuance here about our ability to travel or fly and whether or not it means we can drive to other places, but the point is still the same. We need to make sure that we can empower and help these patients to understand what information that they're going to need in order to make an informed decision. And I'll turn it back over to you, Ron.
Thanks. So looking at the next slide, let's talk a little bit about the stated purpose of this transparency rule, which is this idea of healthcare consumerism, that plan participants or patients are going to shop around because they're given price transparency. And I understand that there are individuals who are on high deductible health plans or have a large percent co-insurance or a share of the price. One of the issues or sort of responses to that we've heard in the past is, but those individuals, they're just going to avoid health care until something big pops up, at which point they blow through the high deductible in one shot, and now the plan is sort of saddled with this high dollar severe case. And hopefully it's not a complication arising from their failure to seek care previously. So, you don't want people to avoid care. You want people to be healthy. That's the whole point of a health benefit plan in the first place. But you want them to care about the cost without necessarily punishing them by sort of dumping the entire financial burden onto their back. And how do you do that? And that's, I think, where things like quality metrics come in, because regardless of whether I'm paying for the film or my father is buying the tickets, I still want to see a good movie, right? And so I think that ultimately we need to address the elephant in the room, which is the fact that a consumer, by definition, is someone who consumes. So when we're talking about consumers, we're talking about the patient. But we assume under a standard economic theory that the one consuming is also the one paying, which is not necessarily always the case here. So I think that, and it's interesting, I think insurers and plan participants, they are actually paying for the care, and I mentioned this before, it trickles down, but there are so many degrees of separation between the cost of the care and their eventual premium or contribution increase that they don't necessarily appreciate one impacts the other. And the other thing is, and this goes back to my college days, is the prisoner's dilemma. And I think that's really ultimately what we're dealing with here. If you know anything about the prisoner's dilemma, it's about how self-interest drives a person to put their needs ahead of the group. And in that example, basically, if you confess to the crime, your sentence is reduced as low as it could possibly be, and everyone else's sentence is going to be high. If nobody says anything, the net impact across the board for the entire group is actually the best possible impact. But if only one person confesses and no one else does, that one person has an even better outcome, even though everyone else is worse off. And so this is a sort of a society psychology experiment where they're trying to figure out, how do you get people to sacrifice their self-interest for the greater good? And what they've discovered is basically the only way to really get that outcome is to reward the behavior that you want to see and punish the behavior that is to be avoided, right? But how do you do that? How do you do that with healthcare? So, I mean, if we can go to the next slide, actually. So, I mean, unfortunately, if only one person is greedy and everyone else is selfless, that greedy person wins, right? If everybody's contributing into the plan but nobody's using it, and then I need some sort of a big surgery, you know, all that money is sitting there for my use. I really don't care what it costs. So how do you share the wins and losses with everyone as a quote unquote group or society, right? And that's, I think, where we as plan administrators and entities that are servicing those plans, we need to get creative, right? We need to stop just accepting the status quo and use these tools that are being provided to us. Transparency, it's not a cure-all, but it's a tool, right? I'm going to steer my patients to the best quality providers. That's on me. That's on me as a plan administrator to use that information and digest it and box it into something that's easy to understand and easy to use to incentivize its use. Don't just assume by telling people, oh yeah, this place is better than that place, that they're just going to go for it. Because if that were the case, everyone would be driving the same exact car, right? What's the safest car on the road? Oh, it's this one. It's this Volvo. Okay, everyone's going to buy the Volvo. And yet they don't. Why? Because of things like the physical appearance, the way it handles, the cost. There are other things besides just quality that drive decisions. Same thing with healthcare. We're going to need to consider that and incentivize certain behaviors. Same with price, right? It's not just about the cost of the healthcare provider, but the quality to price ratio. So you want people to know, but you also want to build it into the plan and use these rules as tools rather than a be-all, end-all. And I think that's ultimately what I get from all of this. So with the takeaways, Brady, if you want to go ahead and close out the transparency discussion.
Yeah, you know, I've been thinking of another good analogy to use when we think about price transparency and how it only goes so far. And I think one is, they say that sunlight is the best disinfectant, right? But it doesn't matter if everyone has the same disease. And I think that's the way to think about this, right? If the bigger issue here is inflated insurance billing. So if everyone is getting together and colluding for really high prices for your in-network rates, it doesn't really matter if they're posting them on their website in a machine-readable format, right? We have to understand that as much as the administration may not want to hear this, price transparency does not really solve the problem here. It only goes so far. It's a good first step, but we really need legislative action on these larger issues like surprise billing, like prescription drug prices. And so once we see that, or until we see that, I think we'll be having these discussions over and over again. And that's how I close it out. Ron, back to you.
All right. Well, you know, you say it like it's a bad thing, but I got to say, everybody, I enjoy these discussions. So, but maybe we could have conversations about how things are going really well. And let's face it, I don't want doom and gloom here. There's enough bad things going on out there. This is a step in the right direction. I'm just saying that transparency rules and these pricing rules that we're seeing, whether it be through the Trump administration or if Biden should win the election, the Biden administration, we can't stop and sit on our laurels and say, hey, that's going to solve the problem. These need to be tools that we use to improve our plans. And in so doing, by making our plans better health benefit plans, plan participants, even healthy ones, will be willing to pay more to be enrolled in our plan because it's worth the money. That's how we win. So, ladies and gentlemen, thank you so much for joining the Phia Group for this excellent webinar, if I do say so myself. But be sure to join us for the next webinar on the 20th of October. It'll have a cool October Halloween theme. I would give you candy, but I'm not allowed. But that being said, we will talk about some of the spooky practices that we're seeing out there that are kind of scary when we tell you about it. Be sure to join up. Keep an eye on social media for the link. And otherwise, please be well. And thank you so much for joining the Phia Group. Once again, we appreciate every single one of you. Be well.